Hello, Avi Sunai there? Are you able to hear me now? Okay, I'm hoping Abhi Arisha was I'm able to see the response on my microphone. So, okay, coming back to our discussion. Now, in this image, if you can see, what is happening is whenever you give an adrenergic drug, whenever you give adrenaline, for example, the most common of the adrenergic drugs, what will happen is you will get different responses from different receptors. So if adrenaline is acting on alpha 1, I will get the responses mentioned there. If it acts on alpha 2, see, it will invariably act on different receptors, because adrenaline is non-selective. It is a hormone, or if I give it as a drug as well, it will replace the hormone and it will be non-selective. Here I'm talking about a drug. When you're giving asthmatic patient adrenergic drug, you are giving a selective drug, meaning it will select between which type of receptor you want to stimulate, in the sense that in asthma I only want to dilate my bronchi. Okay, so here, hold on, cannot enlarge it. If you can still see the image, if you can see this part, I want only bronchodilation to happen. I do not want tachycardia. I do not want anything else. I don't want myocardial contractility. I only want bronchodilation to happen and vasodilation to happen. So I will selectively try to what you call stimulate only beta 2 rather than stimulating beta 1. I will try to stimulate beta 2. I will not try to stimulate alpha 1 or alpha 2. I specifically want this fellow to be stimulated. So what I will do is I will give a beta 2 selective adrenergic drug, meaning that adrenergic drug will mimic the sympathetic system, no doubt. It will work like adrenaline, but it will only act on beta 2 receptor. Okay, it will not act on any other receptor. For example, in that same old example, I had four students. Now let's suppose the four students are student A, B, C, and D. Okay, in different classes, class 1, 2, 3, 4. Okay, different classes they are. And if I give a general stimulus, for example, I am giving a stimulus that I'm making an announcement saying that tomorrow is a holiday, for example. Okay, I am giving making an announcement that tomorrow is a holiday, or something like that. So I will get a response from all the four of those students. Okay, uh, that I do not want that kind of a response. So here what I'm doing is I am tailor making a response where I particularly go only to class 1, only to student A, and I tell that news only to student A, because I don't want the same response from student B, C, and D. I will not disturb them. I will try to keep the response only to student A. Okay, I hope you understand the analogy. Okay, so here what we are trying to do with the selective adrenergic receptor is only try to stimulate beta 2 rather than disturbing alpha 1, alpha 2, and beta 1. Okay, that is what you're trying to do in asthma. You only want the response from your beta 2 receptor. That is why you are using a selective beta 2 agonist. Okay, I hope you are understanding what I'm telling you. If you have any doubts, please stop me. Now, selective beta 2 agonists, these are primarily bronchodilators. As soon as you give a beta 2 agonist, what will happen is cyclic AMP concentration in your smooth muscle will increase. As soon as that happens, it will cause bronchodilation. Okay, that is the primary effect of CAMP. If there is any cyclic AMP present in any cell, what will happen is it will immediately cause relaxation of that cell to the most degree. So in this case where we are dealing with the bronchi, whenever there is smooth muscle, now you know there is smooth muscle surrounding your bronchioles. So uh, if you have any doubts, go look over the structure of bronchiole. कैसा रहता है वो? There will be smooth muscle surrounding your bronchi. So what I'm trying to do is, if I increase the concentration of cyclic AMP by giving a agonist of beta 2 adrenergic receptor, matlab I'm particularly, yeah, thank you son, okay. uh, अभी अभी सुनाई दे रहा, मतलब इससे पहले का एक्सप्लेनेशन कुछ भी सुनाई नहीं दिया था क्या?
सर
नहीं सुनाई दिया? आप लोगों की आवाज क्लियरली नहीं आ रही, बहुत टूट के आ रही. आई डोंट नो हु स्पोक दैट, वाज दैट दिनोंग?
No, sir, we can hear.
You can hear, all of you can hear. Is my voice choppy in any sense?
No, sir.
Okay, एक second. If there is any audio problem, please let me know. I'll switch my vertical. I just switched my earphones, so if you have any problem, I'll switch to a different one. You can hear? Okay. Uh, I'm hoping every one of you can hear. So now coming back to this thing, what is happening is whenever you give a selective beta 2 adrenergic receptor, it will selectively stimulate only beta 2 receptor, the result of which will be bronchodilation. What you'll end up with is bronchodilation. Okay, that is what you want in asthma. You specifically want bronchodilation to happen. You don't need to go into this much detail, but this is the functioning, how it will happen. It will increase the conductance of a large calcium sensitive potassium channel. In turn, the airway will become larger because of a smooth muscle relaxation. All right, that is how it will happen. That smooth muscle, it will lead to membrane hyperpolarization and ultimately relaxation of the membrane. Because of this, your bronchi will dilate. That is the end result basically. Okay. Another thing these beta 2 adrenergic agonists do is, other than bronchial smooth muscle dilation and bronchial smooth muscle relaxation, uh, these will avoid or they will not affect cardiac function. So if you remember, I told you that beta 1 receptor has cardiac function. Beta 1 receptor of beta 1 type of adrenergic receptor is present in your heart. Beta 2 is present in your lungs. If you are not giving a selective adrenergic drug, let's suppose I'm giving a non-selective beta adrenergic drug or non-selective beta agonist, meaning that fellow will non-selectively, it will not select, and it will stimulate all types of beta receptor. I how I know that is, I'm telling, it is a non-selective beta agonist, meaning it will only stimulate beta receptor, but it will not select between beta receptors. It will not differentiate between beta 1, beta 2, beta 3. Okay, it will stimulate all of them. One problem with that is, if I'm giving it an asthmatic patient, that can stimulate hypertension as well, because you know beta 1 stimulation will cause myocardial contraction, and it will cause what you call increase in force of contraction. It will cause tachycardia, all of that. You don't want that. Right? You do not want stimulation of beta 1 receptor. So that is one big advantage of giving a selective beta 2 agonist, especially in case of patients who have cardiac problems. In them, giving beta 2 selective beta 2 adrenergic receptor antagonists are very, very helpful. So now these are subcategorized into two parts. Okay, one is long acting, one is short acting. We'll be concentrating on long acting first. You'll have short acting as well, but that's very small. So long acting, basically it will work for a long period of time, for a couple of hours. So for example, if I tell salmeterol or salbutamol, salbutamol is also a long acting. So this fellow, not long acting, mid acting, not exactly long acting. So this fellow is a selective, as the name suggests, it is a selective beta 2 agonist with less cardiac effects. Meaning this fellow is relatively selective, meaning it does have a few cardiac side effects, but not very profound. Okay, once you inhale salbutamol, this fellow will last for 2 to 4 hours, meaning you will not have another asthmatic attack for at least 2 to 4 hours, until and unless it is status asthmaticus, where I told you status asthmaticus is a condition in which asthma patient is not getting what you call, their asthma attack is not getting abated or it is not decreasing even upon giving drugs. You have to take them to a hospital. So generally, a asthma patient will carry a inhaler around. In case if they are having an asthmatic attack which is so severe that even after inhaling the drug, it is not being controlled, that is a condition called status asthmaticus. Okay, that is an emergency condition. Okay, that's something like shock. So in that condition, you'll have to take them to a hospital. But if it is not that kind of a condition, then salbutamol will generally last for 2 to 4 hours. So it will not precipitate. It will not let another asthmatic attack precipitate for 2 to 4 hours. It's especially useful for acute asthmatic attacks where progression is very quick. It is not useful for prophylaxis though. So in the sense that if someone is going, they are asthmatics who are into sports as well. They are athletes who are asthmatic. Now you can be an athlete while being an asthmatic. The only thing is that you have to take prophylactic medicine before you exercise or something like that, because physical strain can what you call precipitate an asthmatic attack. Okay, any form of stress or any form of strain that may precipitate an asthmatic attack. So in that condition, what they can do is they take the drug prophylactically just to be sure that it does not happen. Preventive medicine basically, right? But salbutamol cannot be used like that. There are other drugs, but salbutamol cannot be used like that. But if someone is having an acute asthmatic attack, this drug is very useful. Some side effects of this is palpitation. Now I hope you know what is palpitation. If you're already second year, so I'm hoping that you know what is palpitation. Palpitation, restlessness, nervousness, all of this will happen. These are cardiac symptoms. So this drug is, though it is selective beta 2 agonist, it is not completely selective. It will have a few cardiac side effects. That is why in the first sentence it is written selective beta 2 agonist with less cardiac side effects. Less means it does have a few, right? It is lower than non-selective, but it does have a few, which will include your palpitation, restlessness, ankle edema, throat irritation, all of that, right? They are metabolized in your gut, and your oral bioavailability is 50%. So 50% of the drug will be bioavailable for action. Now it will be there. Duration of action 4 to 6 hours will get the oral, but generally the effect will last for 2 to 4 hours. The drug will stay in your body for a little bit longer. All right. Coming to terbutaline. Terbutaline, see, salbutamol and terbutaline are fairly common drugs that you will see in a what do you call this thing, hospital. Again, from hospital to hospital, it will change what brand they are using, but these are fairly common. This budesonide, all of them, Astalin, Levolin. If you have ever gone to a hospital, then you will know patients are given these. Right, terbutaline is a what you call shorter acting. This thing, terbutaline is a shorter acting beta 2 agonist or sympathomimetic, but this fellow does not reduce bronchial hyperreactivity in the sense that this will have no function on the inflammation. Asthma is a hyperreactive what you call problem as well, wherein your uh, but bronchi and bronchiola become, your whole tracheobronchial tree has become hyperactive, because of which there is excessive amount of mucus and edema being formed. So terbutaline will only cause bronchodilation. It will not affect hyperreactivity in any sense altogether. Coming to the second types of bronchodilators, I hope you understood the earlier part. What is sympathomimetics? What are the examples? And what do they do? They basically cause bronchodilation so that you can breathe easily. All right. If you have any doubts, do let me know. Now, coming to the second one, methylxanthines. Generally, methylxanthines are quite common. Theophylline is one of the most common drugs that is used for treatment of COPD and asthma both. Especially if someone is drinking caffeine as well. Caffeine is also a methylxanthine. Caffeine has an drug-like alkaloidal property. So it is an alkaloid which has drug-like property. So caffeine, theophylline, theobromine, all of them are classified as methylxanthines. What these will do is, if you see this chart, right, the other day I was telling you, now I want the amount of CAMP, if you can see here near my cursor, I want CAMP level to increase in my smooth muscle. If CAMP level is high, I know that bronchodilation will occur. Okay, so how is CAMP formed? Whenever there is ATP in your smooth muscle, that is converted through adenyl cyclase into CAMP, and CAMP will eventually disintegrate into adenosine monophosphate AMP through PDEs. Okay. What I want to do is I want to increase the amount of adenyl cyclase, and I want to decrease the amount of phosphodiesterase or PDE. Because of because of doing both of these, if I talk about a beta agonist, for example, the first one, okay, here it is increasing the conversion of ATP to CAMP, meaning CAMP level will increase. So if I have a substrate and a product, if I increase the amount of enzyme, more amount of substrate will be converted into product, so I will get more product. Okay, that is the first reaction from ATP to CAMP. Now if I apply the same principle to the second reaction, where the substrate is now CAMP, okay, in the first reaction your CAMP is a product, in the second reaction CAMP is a substrate. So only for your understanding, okay, for an example, so here if I decrease the amount of enzyme, in the first reaction if I increase the amount of enzyme, product is increasing. In the second reaction, if I decrease the amount of enzyme, a product will decrease rather than increase. So what will happen, substrate will stay as it is, right? So more amount of substrate will get accumulated. In either case, what I'm trying to achieve is increased amount of CAMP. If more CAMP is present, your bronchi will automatically dilate because of smooth muscle relaxation. All right, I hope you understood the logic here. If you haven't understood, let me know, I'll explain again. See, if you see this part as well, mechanism of action, methylxanthines inhibit cyclic nucleotide phosphodiesterase. So just remember, phosphodiesterase is preventing the conversion of CAMP and CGMP. So you can have cyclic adenosine monophosphate or cyclic guanosyl monophosphate. Sometimes you have GMP as well. They will get converted into, यहाँ पर 5 prime नहीं लिखा हुआ है, but it is the same 5 prime AMP है ये. So it will stop the conversion of CAMP into 5-AMP and CGMP into 5-GMP, 5' GMP. All right, by inhibiting PDEs. If you inhibit PDEs, what will happen is ultimately, see, inhibition of PDEs will lead to accumulation of intracellular CAMP and CGMP, which will in turn cause bronchodilation, cardiac stimulation, vasodilation. See, this is a drug that will not be selective in the sense that it will cause cardiac stimulation, so you can expect some cardiac side effects with this. All right, so you have to be careful with methylxanthines, especially in patients who have cardiovascular disorders. Right. Uh, I hope you understood. This is the basic crux of methylxanthines. All right. These are some other effects of methylxanthine. So other than your its action on your lung, where it is causing bronchodilation, it will cause some other effects as well. Right. So if it is acting on CNS, hold on. I hope you can see this. Right. Hmm. If you're not able to see or not able to understand or not able to hear anything, please do let me know. Now, I mean, the action of methylxanthine on CNS will be, it will stimulate CNS, it will increase motor activity, it will have a sympathomimetic kind of function. Okay, it will improve performance as well. On CVS, cardiovascular system, it will stimulate heart, increase the force of contraction. So see here, you have to be careful. High dose can cause cardiac arrhythmias. So whenever you're giving methylxanthine, especially to a patient with arrhythmia, especially with a patient who has any other underlying cardiovascular disorder, let's suppose they have coronary artery disease or they have some other type of cardiovascular disorder, even if it is hypertension, you have to be careful, right? Because this will in turn cause increase in force of contraction. Whenever force of contraction is increasing along with hypertension, the patient already has hypertension and you're giving methylxanthines, that is increasing force of contraction even more. That will lead to more problems. Ultimately your heart will, the tissue of your heart will get damaged and you might end up having congestive cardiac failure. All of that will happen. You better avoid these drugs in those patients. Whenever you're giving these kind of drugs, you have to assess the risk benefit ratio. So are the risks worth the benefits? So basically you're trying to understand whether the benefits outweigh the risk, meaning when I give this drug I will get more benefits than risks. Or I can also tell it in this way. Let's suppose I have a patient who is almost dying, and if I don't give this drug, they will definitely die. So in that condition, the benefits will outweigh the risk, because if they are dead, you cannot treat them in any case, in whatever condition they are. Even if you are giving the drug and they develop a complication, you can try to treat the complication at least. But if you let them die, there is no point in treatment then, right? So another thing it will do is it will cause vagal stimulation where it is decreasing BP, and vasomotor. So both of this will happen. See, it will have vagal stimulation wherein BP will decrease, but it will cause vasomotor center to be stimulated, which will increase BP. So more towards the lower end, in the sense that more towards vasomotor center. Ultimately, what will happen is there will be a slight spike in BP. Okay, here it is methylxanthine. Whenever I give methylxanthine to a patient, it will cause both increase and decrease in BP through different mechanisms. The problem is mostly it will lead to increase in BP, because here your heart is also involved, where there is increased force of contraction. So ultimately you will end up with higher BP rather than lower BP. Okay, higher than before you gave the drug. Now, on stomach, it will enhance acid secretion and pepsin. So you have to be careful in people with ulcers. In kidneys, it will act as a mild diuretic. It will inhibit the reabsorption of sodium and water. So it will act as a mild diuretic. The urine volume will go up a little bit, and it will increase GFR and renal blood flow. That is also one of the reasons why you will have more amount of excretion of urine. Metabolically, it will increase basal metabolic rate. So the patient might become a little more hungrier, right? If you know what is BMR, basal metabolic rate, the rate at which your body will metabolize substances, whatever you eat. So if you have someone who is a fast metabolizer, right, naturally a fast metabolizer, they tend to be a little more thinner, because their body metabolizes food very quickly, and it will be converted to energy and dissipated very quickly, right? Their body runs on a very, very high performance engine, for example. Okay, if someone has a lower BMR, their engine is not that proficient, or let's say it's not as demanding, it will not require as much fuel. Okay, the BMR will decrease, because of which they might put on more weight. So that is one case. This methylxanthine will increase BMR. On smooth muscles all around the body, it will cause relaxation, especially in lungs. That vital capacity is increased, and it might lead to releasing biliary spasms. So if someone is having biliary spasms, giving this methylxanthine might cause relaxation in those smooth muscles, leading to relief in biliary spasms. And it will inhibit release of histamines. So here it is acting as an anti-inflammatory as well. So this is one important point that you need to remember. Methylxanthines will inhibit the release of histamine. Now, if you remember, histamine is very important in case of asthma, where this fellow histamine was causing what you call dilation, sorry, constriction of your smooth muscles. It was causing constriction of your blood vessels. It was causing more inflammation to occur in that area. All of that. So your methylxanthine is preventing that. Right. Now, talking about the adverse effects, specifically of theophylline. Theophylline is the primary methylxanthine that you'll study. There is one big problem with this drug. It is a very, very narrow therapeutic index drug, meaning a slight, what you call, incalculable increase in the dose. Let's suppose I'm showing you this chart. Now, at 5 mg, okay, if you can see this chart, at 5 mg, there will be minimal side effects. This is the therapeutic dose that you generally give. At 10 mg, slightly a little more. The general, what you call, play area, or the dose in which you can give it, the what you call range in which you can give the dose, is 5 mg to maximum 15 mg, not more than 15 mg. So if you can see this part here, as you keep on going further and further more, ultimately it will lead to death. And the dose that is causing death is not very high, it is just 35 mg, versus the dose that is used therapeutically, which is 5 mg. That is only a 30 mg difference. So if you are giving the drug theophylline, if you are not careful about it, the patient will develop side effects very quickly. And if you can see, they will progress pretty much in a gnarly way, in the sense that initially there will be restlessness, tremors, vomiting, all of that. It will become a little more severe, where there is tachypnea. Tachypnea is increased respiratory rate, right? And flushing. Flushing is because of what you call, more amount of blood rushing to different parts of your body. Basically, there is more amount of blood rushing to the visceral tissue, to put it simply. That is what causes flushing. And hypertension. If it goes even more, it might cause delirium, where the patient will start shouting, crying, delirious effects. Okay, what you see psychiatric patients do. And ultimately, if you go up to 35 mg, it will lead to convulsions, it will lead to shock, and ultimately it can lead to death. So you have to be very careful with theophylline. Especially true in case of children. Children should never be given theophylline altogether, because they very easily develop CNS toxicity. So theophylline should be avoided altogether in pediatric patients. I would say it should be avoided in pregnant patients as well altogether, because it can have what you call, some side effects upon the fetus as well, right? It is the CVS and a CNS stimulant, and ADRs are not dose dependent. It is based on the concentration, so you have to be careful of that. Depending on the plasma concentration, these side effects will be very problematic, right? Especially they can cause GIT distress as well. Now, another thing, rapid IV injection. So some IV injections when you are giving, you have to time it. Okay, you have to time it so that you give it over a period of time. So instead of immediately administering the particular injection in like 2-3 seconds, you have to time it so that you space it over a few what do you call, almost like 30 seconds or 20 seconds. So you slowly inject the drug. If you give it very quickly, it will cause precordial pain, it will cause syncope, right? They will faint. That is what syncope. And sudden death might occur because of rapid increase in plasma concentration. That is the problem here. If there is a rapid increase in plasma concentration, it will immediately go to death, right? So coming to the next class, anticholinergics. These are the other types of bronchodilators. I hope you understood what are methylxanthines. If you have any doubts, let me know. Okay. So coming to anticholinergics, the main drugs that will be what you call classified in this will be ipratropium bromide and tiotropium bromide. Okay. Now cholinergic system or parasympathetic system in general, that will cause bronchoconstriction and it will increase mucus secretion. So whenever I have more amount of acetylcholine being secreted, that will immediately cause bronchoconstriction and mucus secretion. Here I want to do exactly opposite. When I'm treating asthma, I want to do exactly the opposite of acetylcholine. So I'll give something that is what you call similar to sympathomimetic, but particularly it will inhibit the function of acetylcholine. That is why it is called an anticholinergic drug. This fellow will inhibit or stop the function of acetylcholine or parasympathetic activation. So if that does not occur, you will not have bronchoconstriction. In turn, you are basically causing bronchodilation, and it will decrease respiratory secretion. Now you know respiratory secretion. Basically, respiratory secretion हुआ in your bronchi बोले तो what will happen? The space in your bronchi that will decrease. If there are more and more secretions already, when there is inflammatory reaction occurring and you have more respiratory secretions, that will lead to more problems. So in that condition, you would definitely want your bronchi to dilate and your respiratory secretions to stop. Here anticholinergics will be very helpful, right? Now in general, tiotropium will produce a slightly longer effect than ipratropium. So tiotropium is relatively new. That is being given nowadays for longer duration of action because it is longer duration of action than ipratropium. Some common side effects of any anticholinergic, this is not specific to tiotropium and ipratropium, but whenever you give anticholinergics, it will cause dry mouth. Because if you remember the effect of parasympathetic system on your what you call in your mouth, it will cause salivation, right? When you're writing ADRs or side effects of anticholinergic drugs, imagine what will happen whenever I am inhibiting parasympathetic system. What is the normal function of parasympathetic system? Exactly opposite will happen. So those will be the ADRs of this. Respiratory tract discomfort will occur because one of the respiratory secretion will be mucus, which is helpful in keeping your respiratory system moist. You need your respiratory system to be moist for easy passage. You do not want any friction there or any dryness there. So ultimately what can happen is यहाँ पर respiratory tract discomfort इसलिए हो रहा क्योंकि at one point asthma will get resolved, but that side effect will persist for a little bit longer. So after the asthmatic attack has been abated, it might lead to respiratory tract discomfort and dry mouth. Dry mouth because it is stopping parasympathetic stimulation of salivation. Right, salivation will not occur, because of which dry mouth occurs. Right, coming to the next one, leukotriene antagonists. Now, leukotriene antagonists. Now, you know that leukotrienes play a very important role in asthma. How? If you remember the cycle of asthma, you had an allergen which what you call stimulated your mast cells. Mast cells, what you call, didn't directly stimulate your mast cells. Your allergen stimulated your dendritic cell, or basically your APC, from where T cells got stimulated. T cells secreted interleukin 4 and interleukin 5. That if you go over the pathophysiology once again, you'll remember all of this. Interleukin 4 specifically, through plasma B cell, it activated mast cells, and it ended up producing histamine and leukotrienes. And through eosinophil route, which is through interleukin 5, again T helper cell will produce interleukin 5, which will produce what you call, which will activate your eosinophils, in turn ending up producing leukotrienes and other cytokines. So in any case, there is a lot of leukotrienes being produced which will directly act on the mucosa and submucosa of your bronchioles. Whenever this will happen, your edema fills up in your bronchioles. There will be bronchiolar damage, there will be mucus secretion in your what you call bronchioles, and it ends up becoming congested, right? So if you can stop the reaction of leukotriene, you will stop the reaction just before the bronchial stage. So before it can have an effect on the bronchioles, before it can cause edema, before it can cause mucus to be what you call excessively secreted, you can stop this by stopping leukotrienes. So the specific leukotrienes that we'll be targeting through leukotriene antagonists, that is montelukast and zafirlukast, right? They will be leukotriene C4, D4, and E4. These are important subtypes. You'll also have B4, but C4, D4, E4 are primarily involved in asthma. Now, these are prophylactic therapy for mild and moderate type of asthma, but not for terminating asthma. So, if someone has a mild and moderate type of asthma, these drugs can be given prophylactically. Meaning, if they are going in a dusty field, or if they know that they might have a asthmatic attack to the place where they are going. Let's suppose someone is going into a wheat field, for example, and they know that they are allergic to wheat or pollen, wherein it might precipitate a asthmatic attack. In that condition, you can take a vertical montelukast, or basically a leukotriene antagonist. In that condition, you will be able to avoid asthma or exacerbating asthma or causing an asthmatic attack basically. Now, these are generally safe drugs, but there are a few side effects because they are direct anti-inflammatory, or they directly act on your immune system. You will have immune system related side effects, in the sense that you will have eosinophilia, or you will have neuropathy if they occur sometimes, but they will occur, right? And also, you will sometimes, some patients will have Churg-Strauss syndrome. So that syndrome is basically condition in which the patient will have vasculitis along with eosinophilia. The decreased amount of eosinophils along with vasculitis, so inflammation of your inflammation of your blood vessels, that is vasculitis. So that can happen with these drugs. So you have to be careful in that condition. But in general, leukotriene antagonists are relatively safe. Montelukast is a drug that is also used in general allergies as well. Some people have seasonal allergies, right? In one particular season, winter or spring or any particular season, they have seasonal allergies. In that condition, montelukast is also used. Montelukast is pretty commonly used, right? We'll continue with corticosteroids tomorrow. We have like corticosteroids a little bit, four more, and it'll be done. But we have like 1 minute left. You guys have any doubts? Whatever was taught today. If you want me to repeat any particular part, or if you had any particular doubt in one particular part, see, today what we discussed sympathomimetics, what is selective beta 2 agonist. I'll just recap once. Selective beta 2 agonists, where they are specifically targeting only beta receptors in your lung. That was one. Right, it will increase CAMP level in your smooth muscle and cause bronchodilation. Salbutamol and terbutaline were the primary drugs that we talked about. Then comes methylxanthines. They will do the same. They will increase CAMP level in your smooth muscles, and but you can ultimately end up causing bronchodilation. That one common drug is theophylline, but you have to be careful because it is a narrow therapeutic index drug. See, in this condition, you're trying to increase adenyl cyclase and decrease phosphodiesterase so that CAMP level can go up. Right? These are some of the other effects of methylxanthines that we discussed, other than having bronchodilatory effect. And I also told you theophylline is a narrow therapeutic index drug where you have to be very careful with it. Right? Anticholinergic drugs are those drugs that will go exactly opposite to acetylcholine. Right? And leukotriene antagonists are those that will directly inhibit leukotrienes. So I hope that summarizes what we discussed today. If you have any doubts, do let me know.